here. I've got a question from Giuelo. I'm saying that wrong, but it's around the enhancements and additional features at rapid pace. How long do we anticipate it will take to complete a review process of new functionality? That's sort of been answered already, Wayne, but could you just give a...
Yeah. I mean, without sounding like a politician, it depends, how long's a piece of string. So what the functionality that they're adding into it, I mean, as I said on part of the presentation, it could just be a colour change, or it could be a spelling mistake, or it could be a fundamental change, a new functionality. I mean, the quickest we've done an entire app from start to finish is less than 24 hours. The longest has been 9 months, and when I said 9 months, that's not continuously, obviously, 8 hours a day, 5 days a week. It all depends on the developer, their ability to provide relevant information. So, safety case hazard logging in respect of clinical safety, DPIA assessment from a data protection point of view. So it's all down to the developer, really. We try to make it as pain-free as possible from our side. And we have teams, as Sebastian's on our clinical safety team, literally ready and waiting to review what's coming. Some of the more, shall we say, some of the more proactive developers give us a roadmap of up to 6 to 12 months in advance of what's coming, and try and work with us to make sure that we've got it all assessed. And because all our assessment information is published to the web anyway, they know what questions we're going to be asking them. So a lot of developers now, especially the more mature developers, are using that guidance already while they're developing the product before it even comes to us. Yeah. So we are starting to see a lot quicker turnaround with the more mature developers, and a lot of the new ones as well, to be fair, are really embracing it. And it does work well, but sorry, I can't, it really is how long's a piece of string and what the functionality that they're giving. Okay. Next question, yeah.
One very quick question, last
yep.
question. I'm going to make this one because we're going to move on then. It was around SNOMED coding, and question really around, we are starting to get requests for SNOMED CT codes for specified apps. How do we know if these have been NHS approved as such?
Right, so without sounding flippant, we do not approve apps. So every app on the library, the NHS app library, has been reviewed, and we are stating that they have achieved that standard. What we're not doing is we are not saying that these are, for want of a better word, the best of breed. So we're not saying that these are the best diabetes type apps, or the best smoking cessation, etc. We are just saying that the apps that have gone through the library is the source of truth. So they are all the apps. So there's 91 apps currently live. However, in its history, we've had something like 162 apps published, but we've had to remove apps over time that have changed, or the app's gone out of business, so the developer's gone out of business, etc. Or the app's completely changed from one functionality to another one, and it's been re-reviewed.
Okay, thank you very much. Okay,
if you've got any more, Sebastian, yeah, and if you want to drop an email to us, and I'll try and respond to them on an email after.
Yeah, we're going to save the questions. Anything else, we'll pass on to the team. But just to say we're going to move on, folks, because we are running 3 or 4 minutes late. So, but just a big thanks really to Wayne, Malcolm, Maljon from CryptoWire, and also Chris from Washington DC. Thanks very much for dialing in. I know it's early in the morning there in DC, so thanks very much, Chris. And your time for you all. Now, you're very welcome to stay on if you want to for the next part of the presentation, but we can understand if you want to go.
Yeah.
Thanks
Thank
for your time.
You all. Thanks for your time for inviting us.
Thanks. Thank you.
So we're gonna move on to, again, apologies. We knew this would be a rush session, but we wanted to give you a flavour of what's out there and what's topical, and I think the apps session has done that very well. I want to bring in for the next session the pathology and pathology standards. We've spending a lot of time around the pathology workstream, and we kind of a lot of new work that you may not be aware of what's going on. And I want to start with the presentation from the first part. Really should be with Andy Harris, if I could. Joe, have you got Andy's presentation there? And then we're going to bring in Jay for the second part.
I only have Jay's presentation, I'm afraid. I don't know if Andy
Did I have Andy's in a separate one?
Yes, that should be in this. That should be on the separate.
Apologies, 1 second.
I don't know whether Clive is there to. And Andy, are you there, Andy?
Yes, I'm here.
Oh, you are. You're okay. Yeah, we did send that through, I think. Just a few slides. I think it's four slides.
Sorry, I don't seem to have it. Andy, are you able to shoot them over really quickly or share them on your screen?
Yeah, Andy could maybe be able to do that from just share it from his end.
Yeah, I can do that.
Yeah,
Thank you. So apologies for that.
okay.
Praise.
And Andy, I'll keep talking while you're just doing that. So I will let each person introduce themselves again on this section. And again, we're going to try and have just a few 5-10 minutes at the end for some questions, and then next steps for the clinical safety special interest group. And I know that I've just been looking at the number of participants on the call, so we've got a lot of you out there. So if you do think of any questions, try and send them through the messaging system, and we'll try and answer these outside the call if necessary. There's been quite a few generic questions that we've been answering as we go along, but we can't possibly answer everybody's specific questions at the time. So anything that you want to know about, then do let us know, and Jan at the faculty and Joe will be kind of coordinating any specific questions back to the relevant teams. Okay. Well done, Andy. That's great.
Okay, you can
Andy,
see it.
We can all see it, Andy. So I'll hand over to you. If you want to do a quick introduction for yourself, that'd be great. Thank you, Andy.
Okay, my name's Andy Harris. I'm General Manager at XLab, which is one of the organisations that runs the National Pathology Exchange. We work in partnership with Calderdale and Huddersfield Foundation Trust to deliver this service. I'm just going to give you an overview of MPEX for those of you that aren't aware of it. Hopefully you can see the little flow diagram in enough detail. If not, please shout and I can zoom into it. So MPEX is connected to approximately 130 labs across the UK. We're connected to all the labs in Scotland, and we are working on connectivity to private labs in France and also labs in Southern Ireland. Most of those labs are in production, and that's been pushed hard to get that working in order that labs can use MPEX to share COVID tests and results. The basic solution that MPEX provides is for send away tests. So if you run a lab and you get a request for a test that you cannot do, then rather than putting the specimen in a bag, filling a form in, sending it, and waiting for another piece of paper to come back from the performing lab, obviously the specimen still needs to be sent, but the data information is sent electronically, and that's the piece that MPEX does. It also provides functionality to support specimen tracking from one end of the shipping process to the other. I won't bore you by stepping through the flow chart specifically, because hopefully it's self-explanatory, but that's our high-level business process. So we see roughly 5 to 10% of the pathology testing in the UK, and that is primarily blood sciences work and immunology work, but we are seeing more of the other ologies such as serology and microbiology, and we are starting to explore things such as histology as well. So because of that view that we've got, it's not a complete view, but it's a reasonably, I think, representative of what's happening in the labs. We have done some work commissioned by the NHS Digital team, who will be speaking later, to look at the area of standards. And there are really half a dozen areas of particular interest. So there's units of measure, test codes, which is the SNOMED side of things, specimens, reference ranges, and disciplines. Each of those has got its own particular vagaries, and it became pretty obvious how much interaction there was between these different dimensions of a test request and result. Test codes, we see no SNOMED identifiers going through our system. All the labs are using local codes. That's really the case for specimens as well. Discipline is often not sent as an information item in the messages that we see. I think that that's partly a systems issue and partly because you may be requesting a test for, if you like, for want of a better term, a simpler discipline than the one that you're actually working with, so like a supporting request. What we're going to look at as a quick example of this, primarily because it's the most accessible and obvious of these different dimensions, is units of measure. Now, there are obviously standards for units of measure, the most famous one being UCUM, which is one out of the Regenstrief Institute in America, I believe. MPEX does not use a coding system for standards of measure. So these are effectively free text data items that we see coming through MPEX. So on the right-hand side is a rough count of how many instances of that particular unit of measure we have seen over a 3 or 4 year period. I am not a clinician or a scientist in the formal sense, so some of these units of measure mean nothing to me. I'm purely looking at this from what kind of consistency have we got across labs and across test results. So you would hope that if 2 labs are sending the same result type, if you like, obviously COVID is not a good example in this case, but antibody load or creatinine value, then you would hope and expect that they would be using the same unit of measure across labs. That is true in a lot of cases, but there are also at the other end of the scale, there's a lot of variation between some labs for particular tests, and I think for me the biggest pointer to there being an issue, if you look at some of those units, the second one is KU per litre, the third one is KAU per litre, and then down towards the bottom of the list there's KUA per litre. Now my limited understanding would suggest that they are actually trying to say the same thing, but because there isn't a standard that is being enforced or followed, then we're getting these variations in units of measure being used, even though they may mean the same thing. We also see variations. So, for example, nanomoles per milliliter as opposed to micromoles per litre. they come boil down to the same thing, but they've got a different representation, so that straight away makes it harder to do comparative views on the body of data that you get. So this is really down to 2 or 3 key things. The first, most obvious one is that there is no nationally agreed standard for units of measure. The second big one is that everybody's using different limb systems with different implementations for units of measure. Some of those systems could be 30 years old, and they're quite often examples where a specific unit of measure may not actually be possible to implement in a system. So this is really just one simple view on the data. There's a much broader paper that looks at the other dimensions and talks about possible ways of assessing how consistent these various dimensions are across the pathology workspace. One of the things that we've also done recently is go through a clinical safety process in order to comply with DBC 0160, I think it is, and that's where Clive comes in. So he can talk about some of this from a clinical safety perspective. So I'm going to hand over to him now.
Thanks, Andy. So, I mean, very briefly, to keep it short, I mean, Andy, myself, Calderdale did a 3-month piece of work to complete the safety case. I must admit, it's been a long time since I had anything to do with pathology, but for me, it perhaps highlights opportunity, which I think Kay will allude to later on, in the significance of undertaking the clinical safety work. So, for example, I'm minded that whilst XLab is agnostic in this, it is perhaps a good opportunity to lever the DCB 160 criteria to at least start to get trusts thinking about opportunities maybe to standardize in this area. And that's essentially the only point I wanted to make in terms of this committee and its opportunities for taking work forward. So I'm just putting that marker down in respect of opportunity. I'll hand back to you, Sebastian.
Thanks, Clive, for that, and thanks very much, Andy, for this. But the work of the National Pathology Exchange is really important and is highlighting some problems. And I'd like to move on to Jay Kola, and I'll let him introduce himself, just to outline a bit about the National Pathology Programme and some proposed solutions and some ideas. So, Jay, I'm going to hand over to you. If you could introduce yourself briefly, and then we'll bring up your presentation again. The Jays.
Right. So can I actually ask Joe to maybe make me the presenter so I can run my own slides? It's got a bunch of animations. Seem to work okay for Andy, I think. Should we give it a shot?
Sure. Yeah.
We'll give it a go. Yeah. We're trying to limit sharing slides, but if it works, then great, Jay.
I've just said make a presenter, so let me know if that works.
Okay.
Yeah. Let's have a go. All right. Okay. So there's nothing on my screen you can't see, but hopefully you're just seeing just the slides.
Yes, there you go.
Yep.
All right. The only thing you would see otherwise is software code, but oh well. All right. Cool. So I think in fact, so can I just introduce myself, Jay Kola? So I was actually scanning the list of participants. First of all, apologies for people who have actually heard me speak before and kind of heard some of these slides before. I happen to have this title called Lead for Terminology and Innovation. And I think lots of times people don't know what to do and what to call me. They kind of give me vague titles like these. So I started life a long time ago as a practicing doctor and decided, well, there's better ways to help clinicians and patients. And perhaps I thought computers were the way to do it. So I switched, and after switching, I decided, oh, you know, there's this cool thing called standards, and maybe they are the solution to the problems. So I spent a lot of time in the SNOMED world and essentially built lots of cool things there, I guess, but realized that the real world is very, very far away from actually being able to use some of these standards. So somewhat in frustration, I kind of walked away, and this was when I was working for the old Connected Health program. I walked away in frustration, and I said, well, okay, I will go to different parts of the world and see how it works. So I ended up working in the UK national program, working for the Singapore national program, and I worked in the Swedish national program. And I realized the one single truth, that if we have to fix the problem, you got to get to the ground level and actually make it all work together with the people and all the people who are actually involved. So in many ways, this is why the approach that we took for the standards program for pathology is somewhat unusual, I guess. And so far, people have been telling us it actually works better. So if you heard these slides before, as I said, apologies if you haven't, then please forgive me if you feel that we should have been telling you all of this a long time before. But I will start the presentation by saying this work's been going on for about 18 months, and I've probably got 18 minutes to summarize all of that work, which will be impossible to do. Second, as you heard Andy and Clive making the case, there's a lot of things that are actually happening out there where you can imagine there's lots of clinical safety issues, not just in the one single unit that Andy shared, but a lot to do with how results are actually shared. Some of you might be familiar with it, some of you are not. But I always like to then state by saying, people say, well, so what? Where's the patient harm? Why is nobody dying? So, and I think, you know, a lot of credit goes to lots of systems, no matter how old they are, and lots of people trying to keep all of this going. So a classic example of asking yourself is, if I go to a hospital and say, can you give me all the FBCs, the full blood counts that were done last year, within a snap, maybe in 5 minutes time, they can give me a list of how many were done. If I go to the hospital next door and say, guys, across the two of you, could you tell me how many FBCs were done last year? They will probably say, well, we'll come back to you in about 2 weeks, Jay, and they'll give me an answer in 2 weeks. But if I had to do this across all of London, probably take me 6 months or longer to actually know that. And that's just a really simple, you know, simplification of the problem. Now, if we want to exchange FBCs, if you now imagine doing this across the entire country, then that is actually almost an impossibly hard problem, but it shouldn't be, right? And if you look at what is actually happening with COVID, you can imagine this exact situation being played out in many ways, because everybody can make COVID results or some FBC result available in their local hospital or within their trust, because people have been doing this for many years as workarounds. But if you have to do this nationally, we got to do something slightly different, right? And in many ways, the other apology is this program of work, although it's 18 months old, maybe for the past 18 years, there have been many attempts at actually doing this work or actually standardizing pathology. What then needs to be borne in mind is I am not here to be able to fix all of that legacy of problems. We're actually taking a very pragmatic, let's look at what is needed to do, and let's actually focus on where is the first point of focus or first point where we can actually add value. So having said all that, I do tend to be a controversial person, so please do not take anything that I say out of context, and please do not quote me. I am aware that this meeting is being recorded, and please don't quote me, don't tweet about some of these things, and controversial things especially that I say. All right, okay. If I can now run my presentation, hopefully you will still see the slides. Please let me know when you start to see them properly. I assume you can now see the, yeah, cool. All right, first one, people ask, why are you doing this, right? We're doing this, COVID is a fantastic example of why we're doing it, but we started doing this, as I said, 18 months ago, because part of long-term plan, part of what the future vision of the Secretary of State is all based around interoperability, is all about actually accessing data from different places. Goes back to the app library somebody was talking, right? The second point is, I think, now moot, because Andy and Clive made the point that actually here's some of the examples of why standards and being able to standardize requests and results are important. Okay, there's a whole bunch of benefits there. You guys will have access to these slides, but I don't think we need to belabor those points. Most people on here understand why we need to do some of these things, including why we need better intelligence with COVID as an example, why we need to understand where money is being spent. So if I take the example of FPC, if I say, why is it in the north of England, FPC costs maybe 5 pence as opposed to the south of England, it costs 7 pence. Is it because down south is more expensive, or is it because an FPC actually includes 6 component tests in the south of England, whereas up north maybe they're only doing 5? Now, if you talk to people like GERFT, they will say this is actually very, very important, right? So there's lots of reasons why this work is actually being done. Okay. Moving on, here's the really, really important reason why this work is being done. So people who think, well, all of this, is not new to us. It seems to be working okay. Well, actually, it's working. It's been working okay in primary care for a while because it is based on something called the read codes, which some of you are familiar with, and on an older messaging standard called EDIFACT. The problem with both of these is they're actually now so old that they no longer are being updated. So read's been not been updated since April 2016. And the message standard that we've now got in place can't actually take the replacement for read, which is SNOMED CT. So it was actually, instead of just upgrading some of these systems to say, oh, can you now carry SNOMED CT? Because most of the people who knew some of this knowledge have mostly retired, and the knowledge of people that you can actually count, I mean, how many people there are to actually upgrade any of these infrastructures is probably limited to people you can count on your fingers. We said, let's actually do what everybody else is doing. Let's actually now replace them with the newer standards because we want to build this for the next 20 years, not carry on something that was 20 years old. Yeah. So again, really dummies version of slides. Just so people always ask, is this just about primary care, Jay? No, it's not about primary care. This is about both primary and secondary care. And as you can see, labs talk to both sides of that equation. And in case people are wondering where NPEX actually comes in place, NPEX, and what is not on that diagram is there is a different channel of communication that goes from a lab system to another lab system. And that's where NPEX comes into play generally, and it's been the case so far. So as you can imagine, there's different standards being used, and there's different systems where all this information happens. And every time there's a new system, every time there's an exchange of data, when data is not standardized, there's a clinical risk that potentially happens. Okay, simple statement. What is it that we are actually trying to standardize? Because when I say pathology, some people come to me and say, Jay, are you guys actually trying to standardize all of digital path? And the answer is no, not now, right? So that's why we use this example to say what we're trying to do broadly is that result. Okay, if you take that result down and you break it into the constituent parts of what that result is and what our standards do. So let's take the code. The code's really simple. In that example, it is sodium substance concentration in plasma. You take the example and you break it down and say, well, there could be a value. In this case, it's 142. You can then actually say, well, the units of measure are, and this is a classic example of what Andy was giving, millimoles per liter. Those cases, uppercase, lowercase, are actually very significant. But let's also remember sometimes results also come out as qualitative, high, low, absent, present ordinals as plus, 2 plus, 3 plus. You guys see all this and you take it for granted that actually that's how it works. Okay. Now, to take all this message together, there is one final component, which is the message wrapper that goes around all of it. And that's an example of what this would look like in the world of the new future standards. Okay, we're not here to teach you how to do that. We're here to say this is the broad depth of everything that we are trying to put in place. Okay, so next, if we are actually trying to do this, how are we doing it and what's our approach? So there are actually 5 different streams of work. but you will see the 4 corners. So let's start with the easiest one, which is standardizing what the codes are. And every time you hear the word code, think of it as a test name. So when I say FPC, what I really mean is a full blood count. So if we can all call it the same thing, then we know exactly how many of these things are actually being done as a starter. So that's the UTL, or the Unified Test List. When you hear UTL, things to make. And whoops, sorry, that's just my Mac being weird. Okay, so the next piece is the units of measure. So we are coming up with a standard that will actually encompass the units of measure so people can exchange them without confusion or errors. Third part is what I showed you, which is the message specification or the messaging standard. HL7 Fire is the classic example. People also use V2, or EDIFACT used to be one of the old standards. What we are also aware of is that the world is not going to overnight or at one big bang switch to the new standards. So we've always written something called, we've always proposed something called the information model. Think of it as the abstract representation of all that information, which allows people to say things in the standards that they currently exist in, perhaps EDIFACT PMIP. And if you used information model, you could transform it into the newer standards, UTL and FHIR. Okay, but all of these are actually just in many ways technical artifacts because they can't actually get into practice or get adopted till we engage with the stakeholders. And this is again an important strand of activity that we take forward, but that's why I said there are 5 strands. Okay. Again, when we present these slides, people generally ask us, so how are you actually approaching this, Jay? And how do you know any of this actually makes sense? So we start always from what we call the use case perspective. So we take the clinical use cases, we take the business use cases, and we try to represent them in a shape that makes sense to some of the techies or some of the clinicians. So we go from the left side and into somewhere in the middle. And then once we actually all agree that this is what it would look like, we then move that forward into the new standards. And that's why you see that progression. Lots of times this process is actually iterative. So instead of actually talking to this, I'll give you an example. So if you look at this, this is, by the way, a scenario that was developed by PRSP, if I'm not wrong. So when I said clinical involvement, professional bodies involvement, that's how we engage. We engage with people who understand it. In this case, this example talks about a patient who's got hypertension, comes into the GP, gets a lab test requested, and the result comes back in, and what do we do? So that's part of business as usual for most people. But if you take that result back and represent it in what it would actually turn out to be, so in that case, that was a renal function test. It breaks down into the sodiums, into the potassiums, the chlorine, creatinines. You can start to see that those bits on the left, actually the codes or the standards, SNOMED standards, these bits are actually the values and the units of measure, and these bits are the reference ranges. Okay, that's really the breadth of the example, and we now tie this back into the work we're doing to say, how would each of these clinical scenarios play out, and how would, more importantly, how would our standards support these? Okay, lots of business process planning goes around it. I'm not here to actually explain all the business process planning that goes around it, but if I can just go back to the previous slide ones. So reference ranges. We are not at the moment standardizing reference ranges in case people think, well, are you actually doing this or not? In order to do standardized reference ranges for the entire country, that is a slightly different order of problem, but we'll come back to that in how we are approaching it in the work we're doing. All this material, in fact, there's lots more material available on our collaborative site, but if we can move on quickly, I will talk about the first of our standards, and I think this is generally for most people the most intuitive of them, because most people are familiar with it. They think, yeah, I understand what a test name is and what it should have. So what we do is we take it, a test name, and we say, what would this really look like in a way that
Jay, are you still with us?
Hello, Jay.
Hello, Jay, you still there? I think you might have dropped out. He may have just dropped out. I'll send him a quick message, but can everybody else hear me on the call?
I can hear you, yeah.
Yeah, okay. So, yeah, so we'll come back. We'll try and re-establish contact with Jay. I was messaging him, just giving him a kind of a nudge to start closing his presentation, but I think there are some questions that probably we can try and look at kind of trying to answer, and I think one from Peggy Edwards is very relevant actually, and one we have discussed before, Peggy, and this is to probably to myself and to Clive on the call. What is the level of engagement with Wales? We have a national LIMS system which has been on this journey already, so lessons can be learnt. So I'm not sure of the answer to the Wales engagement. Clive, do you have anything from your NPEX experience at all?
I think
this one, if somebody wants.
Okay, Jay, you're back again, Jay.
I am, yeah.
So you just dropped out. We just to, before I bring you, sorry, we started just bringing some questions because we'd lost you, but welcome back. We've got about another 3 or 4 minutes to run. So if I can hand back to you, Jay, just with that in mind.
Yep, absolutely. So, and I think I was actually going to stop at the next slide. So let's see if I'm still here once I do that. Right. Okay. So here you go. This is essentially the broad model that we built around. What I'd like to focus your attention on is the pieces that go into the standards, and I will quickly move on. I'll quickly move on to say, here's a summary of some of the work we've actually been doing, and more importantly, the governance or the creation, the maintenance process. So I will draw your attention to these things here because we've got 2 minutes or 3 minutes left, right? So this is a work, and remember I said stakeholder engagement as part of one of our activities. This is a piece of work that we aligned with the RCPAP, the faculty, NHSI, PHE, and when I say all of UK, I really mean all of UK because we also engage with the Welsh and the Scottish, actually the Northern Ireland contingent as well, to say, how could we all actually learn from some of this activity that's going on? And that's not just nationally. As you can see, there is a mention of international group. So there are actually other countries across the world who are looking at our work and saying, how could we make use of these standards and actually the approach that we've taken to build these standards. So saying all that, I'll shut it now because I think it's only appropriate for questions to come up at this point, and then we can explain how else all of this makes sense. Sebastian, can I hand it back to you, please? Yeah,
thanks very much, Jay. And that's really interesting. And I was just saying to others while you dropped out of the call, so it's a lot to cover, this, and we may have to think about having a session on the actual standards and how they're going to work in the future. So I just had a couple of questions come through, and if I could, probably Jay, you're best placed to answer this. It's around there is work with the 4 nations was really was the essence of the question. How are we working with the Scotland, Northern Ireland, Wales?
Yeah, so we work at 2 different levels. Obviously, we get the techies to talk to each other so that they understand how the architecture needs to be built, how the standards need to be actually rolled out, and how we could all exchange information based on the same standards. But we also coordinate this at 2 levels of governance. At the professional level of governance, as in the assurance, the clinical assurance, professional assurance, and goes around it, we have what is called the Pathology Information Standards Governance Board, which will include representatives of all of the member countries, so that needs of all the member countries, but also the approaches of all the member countries are actually brought back into the same program. That's the first one. There is also something called the Information Representation Strategy Board, which are actually even much more higher than all of these people who make these decisions for all 4 member countries. That is also a board that we and the PSGB would read into. So because I'm not covering it doesn't mean that we don't talk to them. And in fact, even for the COVID response as well, one of the things that first things we did is we went and found out how the Scots and also the Welsh were actually managing it, within the platforms and the architectures that they've got.
That's great, Jay. Thank you. And I just had one. I'm just going to ask for any other questions from the group to message me. I had one question probably around COVID. And is there a specific COVID-19 work stream around testing and pathology messaging? And have codes been developed for that messaging?
I will answer that without trying to get quiet. And the simple answer is yes. In fact, there are two aspects to the COVID work. And again, Andy is probably chomping at the bits to say, just let me add them, Jay, because here you go. People say, well, Jay, just give us 2 codes or 3 codes and we'll just do all of COVID reporting. And I'm sure Andy will tell you in how many different ways, how many trusts can give you those 3 yes, no, or uncertain values and all the madness that goes around with it. So yes, the answer is there are codes that have now been given out. We were given out 3-4 weeks ago. I don't know now. Time is a blur. What we're also trying to do is just see how we could standardize not just those COVID testing, but also some of the data that comes through from the key worker strands. But let's bear one thing in mind. Because of the legacy of the systems, because of the legacy standards we've got, some of those solutions will actually be just tactical, as in they will work for the current, but they will not be fit for purpose for the next 20 years, 30 years. That's where both these programs are actually complementary to each other.
Andy, did you want to add anything, Andy?
Not really. I could spend the whole 2 hours away with a different labs report just on COVID-19. I'm sure you've got better things to do with your lives.
Okay, well that's great. No, it's a really helpful presentation, Jay, and I know I was rushing you, and so apologies again for that. Because there's an awful lot of information to cover, and what we may do is think about planning further sessions with just focusing on pathology messaging and the clinical safety aspects of that. But I just wanted to thank you, Jay, for presenting today, and Andrew Sunley as well, who's been helping set up the call, and also Andy, of course, who's presented. So thanks very much to you both, and also to Clive for this. We've got there's a couple of other just kind of business matters, so I just want to cover those off before we close. So these special interest groups are intended to be kind of a rolling program for the faculty, and I think the plan is to try and have these running every 2 or 3 months, depending on the availability of speakers and so on. So we'll be looking towards Jan and Joe to help facilitate the next meeting and set something up. It's always useful to know of useful topics of conversation and discussions, and what the clinical safety members and special interest group members would like to discuss at the next meeting. So if any thoughts can be sent through to Joe, Jub, and also to Jan, that would be really, really helpful. But I'd just like to kind of say, are there any other particular questions just before we do close, and comments from Joe or Jan on admin and so on with regard to the recordings and presentations? Jan, can I bring you in here just to mention how do we access the presentations?
The presentations will be going up onto the website. So there's a page which is webinars, and we'll have the recording up there and the slides, and also sort of questions and answers as well going up there. And if it's okay to share that generic safety case that you mentioned, Sebastian, we could put that up too. Yeah,
sure. Yeah, we'll do that. Great. Okay, so I just again say thanks to all our speakers today. It's been logistically fantastic. It's all worked really well. So I'm pleased that we've had dial-ups from Washington and clear presentations. Really interesting session. Apologise if it's been a bit rushed. We always knew it would be, but this is just a taster for the kind of ongoing special interest group for clinical safety. So I'd like to just thank Joe and Jan again for your patience and everything that's been happening in the last week, and for your help in coordinating. So it's been a great job. I've done this many times. It's never it's always a lot of work and a lot of effort required to detail. So Joe, thanks an awful lot. I'll let you all go. We'll be circulating dates and future ideas, but anything you can think of, let Jan or Joe know. Thanks very much for your time, and I'm going to close the meeting. Thanks. Bye-bye.
Thanks all.
Thanks, Sebastian.